Audio recording for this meeting has begun.
Okay, I would like to introduce you to today's speaker, Eric Schell. Eric's a certified public accountant and a Master of Business Administration. He's a principal at Stroudwater Associates in Portland, Maine. And Eric has over 23 years experience in healthcare financial management and consulting. His areas of responsibility are assisting rural hospitals improve financial and operational performance by developing effective, strategic, financial, and operational plans, and evaluating and designing affiliation strategies between rural hospitals and larger hospitals that optimize the combined relationship. Eric also currently serves on the NRHA Governmental Affairs Committee as well. So Eric, I will turn things over to you and make you a presenter right now.
Leslie, are you out there?
I'm here.
Okay, great. Well, thanks, Leslie. We're waiting to the presentation to come up. Many of you attended the presentation last Friday, and I appreciate you for doing that. We do have some new folks joining us. I guess the attendance went up a little bit, so we want to go back starting off and just review a little bit about what we talked about. But one, I have an overarching goal here for this session. We're going to spend probably 45 minutes talking about the cost report. And my overarching goal is to have no one hurt themselves by falling off of their chair, crashing on the floor, from falling asleep. So before we start, please, if somebody's sitting next to you that looks like they're going to fall and hit the floor, wake them up, splash some coffee in their face, whatever you got to do. But let's be safe first before we get into this presentation on cost reports. With that said, as I said in that warning out there, what I hope many of you have handouts in front of you. So this is kind of going to be a show and tell discussion. The telling obviously is me talking. The showing is there's handouts that were supposed to accompany this presentation. The one we're going to focus on is a handout of actually a cost report. It's an abbreviated cost report, but it's about 32 pages, and we're going to use that and reference that, so you can actually flip through this and kind of get a peek at what these documents look like. The next documents that we're going to have, and I don't know if we're going to get there or not today, but there's an income statement and balance sheet from a hospital that we worked with several years ago, and then there's some departmental financial statements, departmental kind of budget to actual, and those are the three documents that I'd like you all to have in hand. I can see the flurry of people looking around the room saying, I don't have any of those, but hopefully we can get by. If you don't have them, maybe we can get by, but if at all possible, I would like to have you guys have those in hand. So again, as Leslie said, and as we tried to press at the last call on Friday, I'd like to hear some interaction from you, and particularly the clinical managers out there, the folks that don't have, that haven't, or they're in this really to learn a bunch, rather than the CEOs and CFOs who probably know all the answers and could give this talk. So what I'd like to do is, in this presentation, just go back a little bit and review some of what we're doing here. Let me figure out how to turn this forward. So I just want to touch on a couple of these from the last talk last Friday. The good news is there was a weekend in between last talk and this talk, so most of you probably through the weekend forgotten a lot of this. The first, and I want to focus on this, underperforming rural hospitals have often allowed a separation between clinical and financial, and the source for that obviously is my travels around the country, and I see the hospitals that really are underperforming relative to better performing peers. There is this separation. The clinical folks say, leave all that business stuff to those people down the hall, or the business people are saying, we don't need to have the clinical people people involved in our operations, and in those organizations they underperform. And so we like to think that we're all in this in order to maintain a place to care for patients. There's a business side of it that we all have to work on, and so that's a big piece of it. The second one is accountability. When I see rural hospitals go from losing significant dollars to making, or at least breaking even, or turning their operations around in a positive way, the words you hear over and over again are accountability and ownership. He or she holds us accountable now. And what I like to think of is that the the backboard or the framework for accountability is into a lot of the information that we're going to be talking about today, and just understanding some of these financial reports, how to use them, why they make sense, why it's important. Historically, department managers have not been provided basic fiscal management tools. You all can look around. You know who's the best. Obviously, who's the department manager for radiology, for lab. They're the best. They're the best techs, and they become the managers without a lot of formal training within our rural hospitals. And so, boy, I'd like to say at least that that we can get some of those tools today, and at least start asking questions. And I just want to jump to the last one. And I've said for a long time now that when we really transform our hospitals from lower performing organizations to higher performing organizations, it starts when we change the questions being asked. And really what we're talking about today is changing the questions that you're asking. After today and what we learned from the cost report, for those of you who make it through, what I'd like to have you do is go to your CFO on Monday or this afternoon or Tuesday and start asking different questions about how you look at your financial performance. Here's some of the objectives that we talked about, and I'm not going to spend a lot of time here, but again, we're going to focus today on two pieces. Understand the cost report as two important pieces. One, for the critical access hospitals, it's anywhere between 40-50% of your revenue. And in those states that Medicaid pays on a cost basis, it's higher than that. But this document is essentially the document that drives over 50%, upwards of 50 to 60% of your revenue. And so as a department manager, boy, I want to understand that as a critical access hospital. For those non-critical access hospitals, and I know there's some of you here now, you aren't really going to be that. The first piece of this isn't that important to you, but in terms of a resource for financial decision making, the cost report, there's lots of really interesting information that's very revealing about your department, that at least if you understood how the numbers are calculated, it'll give you an idea of how people are often evaluating you. And the second piece we're going to focus on today is number 3, and that's just the financial reports, understand basic financial statements, and potentially looking at the departmental budget. So 2 and 3 is what will be the focus for today's session. The last session, I'd like to ask a couple questions right now, on last Friday's call, we looked at the fundamental economics of a critical access hospital, and what I'd like you to do is remembering all the way back to last Friday, I'd like some of the folks out there to hit *# on their phone and share with me what were some of the biggest takeaways around the 3 profitability strategies for rural hospitals, and then possibly the 4th profitability strategy for critical access hospitals, and just share with folks what were some of those strategies and why they were important. I do have a list here, so if you don't, I'm going to call people out. Anyone want to just kind of bounce off and say what was the most important profitability strategy for a rural hospital and why? Doug Tanner, anyone at Washington County Memorial Hospital that wants to shoot out?
Volume.
Volume, absolutely. And why was volume so important? There was two reasons why volume was important. You remember what they were? Does anyone can jump in here? We're going to have this awkward silence until somebody jumps in.
In the chat box, Diane Fair says increase volumes to reduce costs.
Right, and what kind of costs get reduced when you increase volume?
Fixed.
Fixed costs, absolutely. We're diluting. When we looked at our rural hospital cost structure, we all agreed that so much of our costs are fixed or at least step fixed, means they don't fluctuate on a per unit change in volume. And what we talked about was we looked at, for example, what is the incremental cost of one more patient day? If we go from a census of 6, we met another patient that day, we go to a census of, we go to that day census of 7. What are those truly variable costs associated with that one more patient day? And we all agreed that it wasn't much. So one of the profitability strategies, or one of the key pieces of when we increase volume is of so much of our costs, 80% of our costs are fixed. If we drive up volume 1 unit of service, our fixed costs go down for that overall. So essentially we've diluted those fixed costs over higher volume. What's the other benefit of increased volume? So it does, it drives our cost structure, but then there's another piece of it that are important.
Well, one of those things might be that the more you do, the better you are at it, so your processes become more improved and therefore less, again, still a further reduction in fixed cost.
Oh, yeah, I didn't think about that, but you're absolutely right on. We become more proficient at delivering services. So absolutely. The one I was thinking about was for every additional unit of service, not only do we dilute our fixed costs, but we also generate cash, as long as it's a paying customer, obviously. So let me ask you this, for the critical access hospitals out there, what does increasing volume do to you? And thinking about that, think about your Medicare revenue. What happens to your revenue, Medicare revenue, as you increase volume in a critical access hospital?
Well, obviously the revenue is going up, the cost is going down, so you have a larger fluctuation in Medicare costs that's got to be reported on the cost, that's going to be accumulated on the cost report.
So let me try to state what I think you're saying, and that is that higher volume. Yeah, well, I'm not sure. I mean, what for critical? Let me just say this and see if this is what you said, and that is that as we increase our volume in a critical access hospital, because we're diluting our fixed costs and only adding a small variable piece, our actual Medicare revenue per unit of service actually goes down. So our Medicare revenue per unit of service goes down. So if we at an inpatient census of 6, our Medicare revenue or our cost was $1,600 a day. If we increase our census to 7, our Medicare revenue per unit of service might go down to $1,400 a day. So we get less per unit of service, but because we're offering more services, it generally results in more total revenue.
Correct. I agree 100%.
Perfect. But we still get costs, though, and that's the interesting thing. What was another one of the strategies for either reducing losses or increasing profitability within a rural hospital? So the first one was volume, and that was really nice because that both increased revenue, increased cash, and it reduced our cost structure. What's the next profitability strategy we talked about?
In the chat box, it looks like Julie Duty had previously said higher volume will get you profit quicker.
Yep, absolutely. And I'm going to move ahead to the profitability strategies of a critical access hospital, and then we're going to start.
And also in the chat box, Bethany Adams mentioned that decrease expenses and increase fees.
Absolutely. So here, let's just hit on Julie's comment first. Excuse me, no, because Julie, we just touched on that. Higher volumes are going to increase profit quicker, right? Because it's twofold. One, it's additional cash for services generated, and the second is you're declining your cost. Your overall unit costs are coming down. So that's clearly the great strategy. Increasing fees is Diane had a comment, and that's the picture. That's this analysis. That's this diagram that I'm on right now. Where let me just show you. So essentially, it's this orange line that we're looking at here. This is your revenue line, and what happens is that as you increase your fees, this line increases. It goes up, and as it goes up, your break-even point drops back, or your profit. So your break-even point drops back, or if you were at the same level of service, your profit increases. The difference between your revenue is the orange and the blue is your cost. So that difference represents your profit. Okay, so then Bethany Adams said decrease expenses. And that was strategy number this right here, strategy number 1. And essentially this is saying that if our current break even is just above the V there in volumes, if we go ahead and reduce our costs, whoops, went the wrong way. If we go ahead and reduce some of our costs, what's going to happen to these lines? Does anyone have an idea? What line is going to move? Anyone? You're waiting for the picture, aren't you?
Sarah says the orange line.
It will.
The cost line will go down. There we're having a broader range between the profit line and a broader profit zone.
Right, and so what's going to happen, and actually, Dara, you are right as well for critical access hospitals. I'm not sure if you are representing a critical access hospital or not, but Julie and the gentleman that just spoke up, when we cut expenses, and again, I think we all agreed last week that we don't want to ever cut accountants, but usually clinical staff, we've got some room to cut. So when we do that, the blue line drops. So at any level of volume, we have 5 less clinical FTEs. And with those 5 less clinical FTEs, at any level of service, our costs are lower. And what that is doing is essentially saying it's taking our break-even point back from where it was to a lower mark, or it creates profit at current levels of volume. Now to Dara's point, the orange line also moves, but just for the critical access hospitals. And it moves because, if Medicare and Medicaid are 50% of your revenue, it's paid on cost, and you cut your cost structure, then those payers are going to pay you less. But even though they're paying you less, you still improve your profit margin. So your break-even still drops back, or at this level, this is profit of anywhere between the revenue, where your revenue line is, and your cost line times these units of service is your profit. So that's what we talked about. So the profit strategies that we agreed on last year was last week was 1, decrease expenses, but I do know that that's a challenge. 90% of the rural hospitals I go to, we've staffed right, and we've staffed right because if anything, board members understand. They understand when we sponsored that Little League team for $200, and they want to see the check, and they want to make sure we don't do that again. But the revenue, people aren't necessarily concerned about, or they don't really understand, and board members tend to shy away from that. So anyway, expenses generally in most rural hospitals are under control, but it is still, if they're not, there is an opportunity to increase profit. The second strategy was this whole issue of increasing fees, which takes the orange line and moves it up. so that any level of volume, essentially, that we can increase our profit. And some of the things that we talk about there is having a charge master updated, renegotiating our third-party contracts on a regular basis, revenue cycle functions, where all the work that our clinical people are doing is actually getting reimbursed and reimbursed appropriately. Many rural hospitals get into trouble on that one. The cost report is for critical access hospitals. The cost report is solid, and then our service mix is optimal. So that was strategy number 2. Strategy number 3 was this increase in volume, which we just spent some time talking about. And then for critical access hospitals, we had a 4th strategy, and that 4th strategy was around kind of maintaining all volume, but increasing the volume of non-cost-based payers. And what we had talked about was it's all around the slope of the revenue line. Medicare and any cost-based payer, so Medicaid, the slope of the revenue line. So for every additional unit of service, the revenue goes up a little bit. That line is going to be tied effectively to your costs because you're going to get paid based on cost. Now, PPS hospitals, fee-for-service hospitals, or the payer mix in critical access hospitals that's not paid on a cost basis, the revenue line, the slope of the revenue line is much higher. And the reason it's much higher is because for every additional, let's say it's an ER visit, we're getting paid $300 for that ER visit when our costs are only, say, $35. And when I'm talking about our costs, our true variable costs, when we go from having the 22nd ER visit a day to the 23rd, what are truly those variable costs? That's this move right here, I'm pointing out, versus the revenue of this move. So you have a much steeper sloped revenue line for non-cost-based payers and for the PPS hospitals out there. And so one of the goals within critical access hospitals is to increase the slope of the revenue line by getting additional payers or getting additional volume from payers that pay based on a fee-service basis. And in that case, many of those, a lot of that business is essentially your outpatient business, where Medicare makes up such a very small piece versus inpatient. So that's a rehash from last week. Maybe it took a little longer than I thought it was going to. Any thoughts or questions before we get into the talking a little bit about the cost report? Okay, if everyone would move to the edge of their chair, we are now going to talk about the cost report. First of all, there is a handout. It's a 32-page example of a cost report. Do people have that? I get a couple of yeses or nos. Let's see. Anybody?
Yeah, this is Ken Cox of St. Helena Parish Hospital. I have the handout.
So you do. So we actually got those. So all right, great. Others, yes, I have it. Okay, so you have that as a handout. Fantastic. At least some of you that are reporting. Let's take a look at this because again, the two important parts of this is one that for critical access hospitals is a big piece of your revenue, and it's this document right here that essentially drives your revenue. The second is for non-critical access, or the second important piece, and this is relevant for PPS hospitals, is this accumulates information that's very useful in evaluating the performance of your department. And we'll talk a little bit about that here in a minute. So here's in essence, if you want to start flipping through the cost report, your handout a little bit, just to get a feel for this thing. Yeah, they actually do exist, and yes, the ones that you see in your hospital probably are bulkier. I trimmed out all of the schedules here that aren't really that important. But really, what the cost report does at the highest level, 30,000-foot level, is it takes your expenses and revenue, and starting with your expenses from your trial balance. In other words, what your accountants accumulate in your hospital, your financial statements, and it takes those expenses and it drops them into a template that Medicare says, we want you to put your expenses into this template. It then takes your expenses, and Medicare likes to see certain things in certain places. They like to see, for example, interest expense first broken out so they can see what it is, but then they want all that expense moved up into capital costs. And so they also don't like to pay for things twice. And so, for example, if your emergency room physicians are getting paid on a fee schedule basis, we don't want to have to pay for that twice. So we're asking that some of those costs get carved out. So the first step it's taking our expenses and dropping them into this template. The next step, and I'm down now to part 3 here, is in order to come up with the costs for clinical departments, what we have to do is we have to take all of our overhead. So your CEO and CFO's salary. These are folks that generally don't provide any value at all to the. Wait, no, I didn't say that. These
I think a lot of you too.
and lofty consultant fees if a hospital is using consultants that are providing no value to your organization. What we want to do is we want to allocate all of those expenses down into the clinical departments because Medicare is only going to pay for clinical services. So what the hospital has to do, and often these are called administrative expenses or overhead expenses, those represent upwards to 35 to 40% of the total costs within your hospital. It's the clinical departments, the direct costs associated with clinical departments are usually around 60%. So step 3 is saying we've got to take all of these overhead expenses that aren't directly a part of the clinical departments, and we've got to throw those into the clinical departments. So you guys in lab and radiology and nursing, get ready because you're going to catch a boatload of money or a boatload of costs here. Just hope it's worth something. The next thing that we have to do is we have to calculate, in order for Medicare to figure out how much they're going to pay, there's 2 different calculations. There's a calculation for outpatient services, and that's pretty easy. The calculation for outpatient services says, let's look at radiology. Let's say radiology starts off with costs of $1 million. Overhead expenses get dumped into radiology, and so now radiology expenses are $2 million. Medicare, we bill Medicare charges. So let's say in this hospital we billed Medicare $500,000 in charges. We have to figure out how much costs relate to that $500,000 of charges that we billed. The way we do that is if we take our $2 million of cost and we divide that by our total charges that we bill out for the radiology department, let's say it's $4 million, we come up with a ratio. And it's this ratio of our cost, which is $2 million, to our charges are $4 million, it's a 50%. For critical access hospitals, if we then take what we billed Medicare, say $500,000, we multiply it by this 50%, Medicare costs become $250,000. And that's what the cost report's doing. It's essentially taking our costs, coming up with these ratios, multiplying by these ratios by what we billed Medicare in charges, and to come up with what the Medicare costs are. And that's how critical access hospitals are reimbursed. Everybody completely clear on that? Yeah, of course you're not. We got to see the whole calculation. At this point, check the person next to you just to make sure they're okay. Now on the inpatient and swing bed basis, there's 2 calculations. One is for an inpatient stay, there's the ancillary costs, so the labs, the x-rays, the physical therapy. And essentially for those components of cost, we do that exact same calculation that I just walked you through. We come up with these ratios. We multiply the ratios by what we billed Medicare from an inpatient ancillary perspective, and we come up with the cost. The second piece of this calculation is we have to figure out how much of the nursing costs. And the way we do that is we take our nursing department costs, we divide it by the total patient days, and we come up with a cost per day. Let's say it's $1,000. We take that $1,000 You multiply it by the number of Medicare patient days, and you come up with how much Medicare owes for critical access hospitals for nursing services. Now, we compare what Medicare's costs are, and again, critical access hospitals, to what was paid out during the year, and we come up with a settlement. So at the highest level, that's what a cost report's doing. And again, I wanted to go through that at a very high level, because then we're going to get a little bit into detail so you can see how this is going to work. I've had people say that essentially if they understood the methodology of the cost report becomes much more of a living, breathing document. If you just try to look at the numbers and get overwhelmed by the numbers, then it's really a useless document. So again, what we really want to do today is just walk through the philosophy of it, the methodology, and then it could be a useful tool to you even within your clinical departments. So the first page, and what you'll see is on the top here it says S3, Complex Statistical Data, page 5. In the handout, yeah, who's that?
We are not a critical access hospital.
Yeah.
So while you're explaining that, could you also kind of explain to us how ours would be reimbursed as compared to what you're saying critical access?
You guys, are you still held harmless for outpatient departments? As long as you're still held harmless, there is a settlement. So essentially, for Medicare outpatient costs, you're held harmless to what, 85% of your outpatient costs. So if that's the case, at least for outpatient services, that there is an element of having your costs accurately stated in the format that we're talking about right here. For inpatient services, the non-critical access hospitals are paid a straight fee schedule, and it's the DRGs times your base payment, and you come up with a payment amount per discharge, and that essentially is not really reconciled to costs, and so it's for the PPS hospitals, it's only the outpatient piece that there's a portion of it which is tied to the Medicare cost report. For you all, the interesting part of this presentation is going to be the information that you can get out of it to really assess the departmental performance within your organization. Is that helpful? Lost you. Okay.
Somewhat.
I have to tell you, for the non-critical access hospitals out there, this presentation isn't nearly as, this piece of the presentation, this day, when we're talking about the cost report, is not nearly as important as it is to the critical access hospitals. Okay, so I'll give you that right now. Again, but there is really good information. So if you're patient with me, we'll get to all the really good stuff, which is around the financial statements and how to evaluate performance, etc. So anyway, page 5 of your handout, and if you want to flip to it, just so you can take a peek at page 5 within the handout, you'll see exactly what you see up here on this slide. And essentially, this S3 accumulates data. And you can see this is a critical access hospital. You can see in the columns. Column 1 is the number of beds. Column 4, Title 18. Title 18 is your Medicare. And so if you go down the column, the 2,097 is your Medicare, and you come over here to it says row 1, adults and pediatrics. So this is your Medicare acute patients. If you go to column 5, Title 19 is Medicaid. And if you go all the way down here to column 6, so it would just continue on out. So you have 5, and then 5.1 drops down to 5.2. So then the total patients, so this hospital had a total acute count for the year, patient days of 3,600. So they were running an acute census of around 10, of which Medicare was about 58% of that. You go down to the row 3, you've got swing beds. These are Medicare swing beds. And column 6 is Medicare and Medicare Advantage swing beds, so it's a total. This hospital had a nursery, so you have nursery days here, none of which were Medicare, thank goodness. and then observation beds. And it's really important that you get your observation bed days here, even for PPS hospitals, because this accumulates costs. There's a formula that's calculated in the cost report that you want to make sure you get your observation bed days correct. Okay, so this is the worksheet that accumulates statistics. For critical access hospitals, it's really important we get this correct because it'll drive your calculations and your reimbursement. The next worksheets, and here, if you want to take your handout, and I want to walk you through a little bit. If you look at page 6, is columns 1, 2, 3, 4, 5. Page 7 is columns 6 and 7, so it just continues on. 1, 2, 3, 4, 5, 6, 7 is pages 6 and 7. This is your worksheet A, and I'm going to talk a little bit about what worksheet A does. The next pages 8 and 9 is your worksheet A-6. These are your reclassifications. They don't change any bottom line effect. They just move numbers around so that Medicare has, so you present your financial information or your costs in the way Medicare wants to see it. And then your next is your worksheet A-8. These are your adjustments. So these usually either add to or subtract from your costs. And I'll show you, we'll talk a little bit about those, and that's on worksheet 10. And then page 11 and 12, they're just additional information related to your adjustments. So there you are. You have your cost report in your hands. You can see it. Remember at the 30,000-foot level that we said that the first thing we want to do to the cost report is we want to take our trial balance, so our information out of our financial reports within our hospital, and drop it into this Medicare cost report template. Well, worksheet A is this first level of dropping our expenses into this template. And if you look, if you, in your handouts, if you start looking at the way the expenses are laid out, you can see they're broken out, all the different departments going down the left-hand column, and then you see the expenses are broken up between salaries, all other expenses. You have total, then you have reclassifications. You flip the page, you have adjustments, and then they'll total up to adjusted and reclassified numbers. Okay, so again, the worksheet A, and we're going to flip to the next slide to talk a little bit about that. In worksheet A6, we talked a little bit about that. That's on page 8 and 9, and that's reclassifications. Worksheet A8, these are adjustments, and you can see each of the pages is defined here. All right, now this is that page 6, and so again, worksheet A. What I've highlighted is a couple things we want to point out. Everything highlighted in red. So these expenses here in column 1 and 2, and then totaling up in 3. These are all your overhead expenses. So these are expenses that aren't directly attributable to your clinical departments. And you look at them and look at the magnitude of these. You've got 1.6 million in employee benefits. You've got $2.7 million in admin in general. You've got probably a lot of that's your CFO's salary because that's the value they bring to the organization, I would suggest. You've got housekeeping, 175. You've got nursing admin, 385,000. So you can see that there's some really big expenses bundled up into here. And essentially what the cost report is going to do, it's going to take all of these expenses and throw them down into your clinical departments. The next thing what we have is everything highlighted in green. These are your, well, it starts off, the first up until, this is your inpatient right here, adults and pediatrics, your nursery. The next kind of heading here is ancillaries. So here's all your ancillary departments starting in row 37. And they go all the way down to rows 39.5. Then you have your outpatient departments, and you have your clinic and emergency and observation beds. And then once we get out and we get below this green box, we get into departments that aren't reimbursed based on cost. They're kind of home health, ambulance, hospice, all a bunch of stuff down here that don't necessarily get reimbursed based on cost. The breakout again is you have salaries, and then you have non-salary, and you have totals. The way the cost report is set up essentially is the departments at the top, So in the overhead section, the departments at the highest level, this is your capital cost, this is your depreciation. The reason why they're at the top is because when we go to allocate them, essentially any department that has square feet is going to get an allocation of some of this cost. As you go down, it gets more and more specific. Employee benefits is allocated to almost all departments as long as they have staff. Admin in general is going to get allocated. But if you get down to cafeteria is generally going to be allocated just to some clinical departments. Nursing admin is just going to be allocated to clinical departments. But essentially all of these costs are going to get dumped into your clinical departments, and I'm going to show you how that works. So that's worksheet A. Again, highest level. Takes our trial balance expenses, breaks them out between salaries and non-salaries, and then lays them into this framework. In column 4, we have these reclassifications, and ultimately they just move money, dollars around to get them in a format Medicare wants them to be in. We turn the page, and it's specifically the page in your handout to page 7, and you come away essentially with column 7, which are net expenses for allocation. The adjustments, I just want to spend two minutes talking about adjustments. So for those of you who have handouts, remember how we talked a little bit about, and this would be on page 10, and those of you who want to just turn to page 10, essentially adjustments, as I said earlier, are either going to add to or subtract from your costs. And if you look here, you've got a big cost in this hospital related to, and this is $2.7 million, provider-based physicians. A lot of this is going to be your ER physicians. Anytime your ER physician is going to be seeing patients on a professional level and we're going to be billing Part B or we're going to be billing for professional services, we got to carve the portion of that ER physician's time out as an expense reduction. If we have for example, if we have a radiologist, we employ a radiologist that bills on a professional basis, we'll have to pull that radiologist out. If we have a general surgeon that's billing professional services, we've got to pull them out. So that's that $2.6 million. And you can just look down through and see some of the expense reductions here. And this hospital had almost $4 million of adjustments come off their cost report that Medicare essentially said, you're either getting paid through another avenue, for example, professional billings, or here's one, we're getting vending in, row 22, vending machines. We're getting $11,000 of revenue from vending machines. We're not going to allow you to put that expense on. We're going to have to make sure that you back that expense off of your costs. Okay, so adjustments are really important, and often you see some mistakes around those, and so it's really important we get those right. Okay, the next worksheet is worksheet B. And again, if you flip to your handouts, worksheet B, we're looking at pages 13, 14, and 15. And pages 13, 14, and 15, this is how we allocate costs. So if we start with hold on, let me just explain these here first. So worksheet B, these are the dollars that get allocated, and this is how we actually allocate. These are the numbers that get allocated down to your clinical departments. Worksheet B1, and this is on page 16 and 17 in your handouts, these are the statistics that are used to allocate the expenses. And I'm going to explain this in a minute because I'm sure this is absolutely sounding Greek right now. Ultimately, what we want to do is we want to accumulate statistics. We want to use those statistics to take our overhead expenses and allocate our overhead expenses down into our clinical departments. So that's what we're trying to do at a high level. Let's look at how we're going to do that specifically. If we look at your handout on page 13, we have column 0. Column 0 is $16,400,000 total. Where do we think that number has come from? Anyone have any guesses where that number may have come from?
That's net expenses for allocated costs.
Right, that right there is the, if we were to go back to the worksheet A that we just talked about, and if you look on page what was it, page 7 of your handout, row 0 in worksheet D is essentially, it's just picking up column 7 of your worksheet A. So we're just picking up those expenses that we just got into the template Medicare wanted to see them in, you reclassed, adjustments, etc. We're going to pick that up from A. We're going to take it and drop it into worksheet B, column 0. The next step, as we talked about, is then allocating, taking this $206,000, we're going to move it over to column 3, and then we're going to allocate this $2,000. This is depreciation on your building. Okay, see it says capital cost building. This is $206,000 as you depreciate. We're going to take that, and we're going to allocate it to all of the different departments that have square feet within our hospital. And when we allocate that, and I'm going to talk about how we allocate that, but when we allocate it, essentially what happens is this department goes away. That $206,000 then becomes a piece of everybody else, and it's gone. The next thing we do is we move the $380,000, over to this column, and then we allocate this down to all of the departments. Can you guys see my arrow as I'm moving it? Just quick, yes? Hope so. I'm going to assume you have. The next thing we're going to do is we're going to take
We aren't able to see the arrow, but there is, on the top toolbar, there is an arrow button that you can use, a green arrow, that I'll be able to see.
Oh, you haven't been able to see my arrows?
No.
Oh, I've been drawing smiley faces and everything with it. It's
there
too
you
bad.
go. Now
There we go. All right. Now watch the green arrow, guys. We're going to be taking employee benefits from column 0. We're going to pick them up. We're going to bring it over to column 5. And then we're going to allocate this $1.5 million down to all of the different departments. And when we do that, this department, employee benefits, goes away. We're going to do the same thing with admin. Now, here's the interesting thing about admin in general. Administration in general, this is your CEO, COO, this is your revenue cycle functions, etc. They start out at $1.9 million. But to them, they get some depreciation in column 3 added to them. They get another capital cost in this department. They have a bunch of employee benefits. So now they've gone from $1.3 million to $2.1 million. We carry them over to column 6, and we're going to allocate admin in general to all of the other departments. Hey, any directors of nurses or chief nursing officers? Look what you just got dumped by admin in general into your department, $385,000 of kind of probably bloated overhead. The plan operations, so ultimately what we've done is every time we've allocated all of these expenses down, these departments, essentially we eliminate them. So when we're all done, and when I talk about when we're all done, if we flip to our handout and we go to page 15, actually page 14 is better. Page 14, we're left over with just our clinical departments, and those clinical departments have been loaded up with overhead. So kind of interesting, and I'll tell you why that's interesting in a minute. So first of all, how is it that we're going to allocate 17% of depreciation on the building to our adults and pediatrics department? What do you think would be a reasonable methodology for allocating depreciation expense?
Square footage.
Oh, there's a CFO. Square footage, right. And square footage is generally how we're going to allocate that. And so what I want you to do now is we're going to jump back and forth here. We're going to jump to page in your handout. We're going to jump to page 16. And so what we've got here is in page 16, column 3, in order to allocate the depreciation on the building, somebody has entered in the total square foot of our facility. This hospital is 47,683 square feet. And it's made up of all of these different departments. Admin in general has 5,300 square feet. Operation of plant, let me just use my arrow here. Operation of plant is 2,091 square feet. We got some, what is that? Housekeeping is 39 square feet. Our med surge unit has 8,339 square feet. And you can just see, in all of these, if you add them all up, they total 47,000 square feet. So now, if you were to take the 8339, divide it into the total square feet, so if we were going to take the 8339, which is your adults and pediatrics, divide it into the 47,000, you come up with 17%. If we go back to the worksheet B, 17% of 206,000 is the 36,000. That's how the adults and pediatrics got credited for 36,000 square feet. Now, if we go back to our statistics page, if we look at let's look at employee benefits. In this case, if we look at our employee benefits, the method that we're going to be using to allocate employee benefits is in this case it's salaries. So the total salaries of this hospital were $7.3 million. Adults and pediatrics were $1.7 million of that $7.3 million total. So if anyone who has a calculator right there and does the math, let's just say that that's 20%. 20% of employee benefits costs of 1.5 million get allocated to the med surge unit. And we just keep going on and on. In administration in general, the way we're allocating to all these different departments is based on accumulated cost. What that means is that the total cost. So in this case, what we've got is med surge at this point is $2.6 million. $2.6 million as a percent of 14 million. Let's say that number is 15%. Med surge is going to get 15% of admin in general. And every time we do this, what happens is we close out our overhead departments with all of the costs of them being allocated to you, or to the clinical departments. Operation of plant. So this is your air conditioning, your electricity, plant ops folks. This is allocated based on square feet. If you flip through your cost report on pages 16 and you flip to page 17, you can see how each of the other departments is allocated. Pounds of laundry is how we are going to allocate laundry and linen. Housekeeping is going to be based on square feet. Cafeteria is going to be based on FTEs. Nursing admin, often nursing admin, well, it's based on nursing FTEs, etc. So we can see how. And now let me go back and I want you to look at this table. And I want somebody in the nursing, well, actually, I want radiology. Radiology started off with direct costs of $1.3 million. When we get done allocating costs to radiology, I want you to look at your handouts. I want you to tell me what the fully allocated costs, because when we're all done with this, the fully allocated costs of radiology, what is it once we get done allocating all of these costs? Anybody want to shoot out a number here based on your handout? Anybody? 1660. Let's see. Diane. Diane, yes, you've got it. The total is it's almost $1.7 million. So for folks in the radiology department, you started off, your true costs were $1.3 million. By the time you get done adding all of these overhead expenses, your costs now are up to almost $1.7 million. Now, look, someone in nursing, here's your cost. They start off at $2.1 million. What does nursing come up to? Any nursing officers out there that want to kind of take a stab at this one? Anybody? All right, I'm going to jump in the essence of time here and explain. In the nursing, after we allocate all our overhead, we're up to we're over $3.6 million. So our nursing department that started off with total costs of $2.1 million now has been bloated to over $3.6 million, which is anyone can say that's a whole lot of cost. And the important thing here is, and we're going to jump here to this slide here because this is the column 27. This column 27 is your fully allocated costs of all your clinical departments. Now here's where it gets interesting because often when our finance folks and our administration start looking at what the costs are in all our departments, often folks focus on fully allocated costs, which are these. And where if in nursing, really the cost that you have a significant amount of control over started off at about $2.1 million. The rest of this is overhead. So we really have to be careful when we're looking at evaluating our performance. Then we go back, and remember our talk from last week, we talked about, convert this back to variable versus fixed costs. So if we'll go back 2 slides, we're starting off with $2.1 million here in nursing, and now we start to thinking about breaking that up between variable and fixed costs. So what piece of that 2.1 varies based on the changes in patient volume? Probably not a lot. But when you get down to fully allocated costs, and the whole increase between 2.1 and 3.6 is essentially overhead, which is really fixed, we've got huge, huge fixed costs and very, very small variable costs. And I think that's a really important lesson for both critical access hospitals and PPS hospitals, is the magnitude of the allocation, which is essentially fixed costs, versus the very small piece that is variable costs. So we're done with column B. Does anyone have a guess? We're done with worksheet A. Does anyone have a guess what the next worksheet might be? We started off with A, and that was where we took our trial balance, our financial statements, dropped them into the Medicare template. We cleaned them up. We came across. We finished off with column 7 there. Column 7 was cost to be essentially cost to be allocated. We picked that column up, dragged it over to worksheet B. Worksheet B, what we're going to do is the function of worksheet B is using statistics, take the costs out of overhead and dump them into clinical departments. The next worksheet, does anyone want to take a guess? You can type it in here, what the title of the next worksheet might be. We started with worksheet A, we went to worksheet B. Doug Tanner from Washington County, you get the prize. You're right, worksheet C is the next one. And worksheet C, this is where we start talking about these ratios, because and let's go to our handout here, because on our handout we're on pages 18 and 19. And pages 18, I don't have it up here on the slideshow, but page 18, column 1 of the worksheet C essentially takes those costs that we just calculated, those fully allocated costs of your clinical department, picks them up and dumps them into this worksheet as column 1. The next thing we do is this is here on the in the presentation. I've got a green arrow pointing around. Is we load in our charges, and we take our charges. We look at our inpatient charges are going into 6. Our outpatient charges go into 7. And these are just technical, so these aren't professional charges. These are just your facility charges. And you get these off of our trial balance again. This is the revenue side of our financial statements. So the worksheet A is the expense side. The worksheet C is the charges. And so now we come up with total charges. If we divide total charges by those fully allocated costs that we just calculated, we come up with ratios. And the ratios are, you're going to hear this RCC. Ratio, and an RCC is a ratio. If I slow it down, it makes sense. It's a ratio of your costs, your fully allocated costs, compared to your charges. In this case, radiology. Radiology has $4.3 million in total charges. if we divide that $4.3 million into our costs, and the costs came off of the prior page, let's see, it's right here. If we take the $1.7 million in cost, divide it by the $4.3 million in charges, we come up with a ratio of 0.38. For every department, there's a different ratio that's calculated. And you can see that. Can somebody comment on what do they notice about the ratios here as we look at all of the ratios for each of these departments? Anyone have any observations? Just wait, before I ask that question, check the person next to you at this point, make sure that they're okay. All right, good, thank you. Once you've done that, is there any interesting observations that we have related to these ratios of cost to charges?
Well, so it looks like some exceed 100%.
Correct. And what does that mean?
You all right?
I just took a sip of water. I went down the wrong path. All right, we're back together here.
It apparently means for the operating room we're getting reimbursed in excess of our costs.
Well, actually, you got to flip that upside down. So it's the numerator in the equation. Ratio of cost to charge is your cost. The denominator is your charges. So in this hospital's OR, the costs, now again, fully allocated costs, and now we all know the difference between our direct costs within our department and when we dump all those bloated overhead costs of our administration and all those folks, you know, it's very different than when we start off with. But in this case, our surgery costs are 101% of charges. Now let me say, for critical access hospitals, at least the Medicare piece of that, that's okay because you're going to get paid 101%. You're going to get that 101% of your charges. But for hospitals that are not critical access hospitals, when we have departments in which our costs are higher than our charges, that's generally not a profit maximizing strategy. So that's
Eric
one
and
observation.
Julie Duty said in the comment box that the higher ones are usually outpatient.
Let's see. So Julie's saying, so outpatient, so higher ones. So you're saying the departments with the higher ratios, oh, I see, you're jumping down here into your emergency room, diabetic education. In this hospital's case, right on, absolutely. Does anybody want to comment? I'm looking for one very specific comment. I've not quite heard it yet. $1 to the winner. All right, I'll give you half my Delta miles. No takers. All right, that offer is off the table right now. Let's see, is anyone typing in anything? No? Doug, I thought you might be jumping in with something. Yeah, right. So Doug actually said that, Doug for Washington County said that yeah, we've got to look, you know, when we see departments, one of the first things, when I look at a cost report, I'll flip to this worksheet C. And if I see departments with ratios greater than 1, you've got to start asking right away. 1, is there an issue with our costs? 2, is there an issue with our charges? 3, is there an issue with our charge capture processes? You know, are we doing everything to capture all the charges? So those are some of the questions I ask immediately when we look at that. Really the answer I was looking for was look at the variability among departments in your ratios. So you have one department here. Now this is a small electrocardiology. Their ratio of cost to charges is 0.07. You come down here to, let's look at emergency room, which is, you know, $430,000 of total charges, so decent charges. They have a ratio cost to charge of 1.57. Physical therapy has a ratio of 1.16, where radiology has a ratio of 0.38. Now, does anybody, let me ask you this. Let's say that your CFO comes to you. You're in the physical therapy department. You're a critical access. We're gonna isolate the critical access hospitals now. Sorry, most of you guys in Alabama. Except for Doug. If you're a department, critical access hospitals, how do critical access hospitals get paid during the year for outpatient services? Well, many of you probably don't know, but here I'll share with you. Essentially what happens is we look at a weighted average basis of all of the Medicare charges that were submitted in last year's cost report. We compare it to all of the costs associated with those charges. And let's say the ratio that Medicare is going to pay us on a weighted average basis for the entire next year is, say, 50%. So 50% of charges they will pay. And it's based on, again, the weighted average of last year's cost report. So now, if I'm the physical therapy department and I go to the CFO and I say, CFO, I want to look at my department to see if we're profitable or not. I know my fully allocated costs from the prior page are $374,000. I know my charges are $320,000. How do I look at, as a physical therapy department manager, how do I look at whether I'm profitable or not?
Eric, there were a couple of comments in the comment box from before. Doug Tanner said RCC, and Hartner Medical Center said low volume departments in rural hospitals result in low charges with result in high RCC.
Yeah, absolutely.
Yep,
and that's
also one more, rehab department and ER department, which has high salary personnel and are not as productive as an urban counterparts.
Could be the case, absolutely. And that's some of the reasons that you're going to look at. But at the same time, you can't, as a critical access hospital, low volume critical access hospital, survive if all of your departments have costs in excess of charges. So we've got to wrestle our arms around that one. Anyway, let me just go. We're looking at our physical therapy department, and I want to evaluate my revenue. So I asked the CFO, how much do we get paid by Medicare? And the CFO says to the physical therapy department manager, well, we get 50% of charges. And the physical therapy manager goes back to does some calculations, says, oh my gosh, we are losing a boatload of money. Was it appropriate for the CFO to tell the department manager, the physical therapy department manager, that 50% of charges was what Medicare was paying his department? Because that's Medicare during the year is paying 50 cents on the dollar. This is a trick question. Essentially, the CFO just gave the department manager an incorrect answer, because the correct answer would be Medicare is going to pay 116% of charges, of the Medicare charges for physical therapy. It just so happens that the 50% that's paid during the year is made up of departments that are 116% of charges, and departments like radiology, or high volume, that are made up of very low ratio cost of charges, here 0.38, all coming in at a weighted average basis of 50%. So we have to be really careful when we evaluate our own financial performance. The other piece that we have to be very, very cognizant of within physical therapy is that when we're looking at their costs, and we just looked at, and I'm going to go back to Worksheet B, their costs here in this case are $374,000. But if we go back to their real costs, their direct costs of physical therapy, they're only $221,000. So what's the real number to evaluate the performance of the departments? And I'm going to hold you to that one until our December meeting, because there's a way that I've kind of created some methodologies for department managers to look at their departments using this ratio of cost to charge information and help them evaluate their own performance. So anyway, back to the cost report, because we're going to have to get through this here in the next 10 minutes or so. the Worksheet C's purpose is to calculate these ratios. These ratios are based on us inputting our charges, inpatient, outpatient, then they total, and dividing these charges into our costs coming off the Worksheet B to come up with these ratios. We're going to jump to the next schedule, and this is the logic here is just unbelievable how they ever came up with this. The next worksheet is Worksheet D. So we started today. That was our costs, getting cleaned up, fixed up, set up for Medicare. Worksheet B, take our overhead expenses, allocate them to our clinical departments. Worksheet C is calculating these ratios. Now we've got our next is Worksheet D. Worksheet D is essentially saying, and again, this is pages 20 through 22 in your handout. Essentially, page 35 here in the presentation, I've just crunched all of these into 3 columns. The only columns that are relevant are columns 1 on page 20 in your handout, column 5 on 21 of your handout, and then column 22, or excuse me, worksheet 20, or page 22, column 9. What we're doing here is we picked up in column 1. We're back here to the page 35 of the presentation. Column 1 are these ratios that we just calculated. There's the 116% for physical therapy. There's the 38% for radiology. There's that 157% for ER. What we're going to do is in column 5, we're going to go in and grab from a report that's prepared Medicare on a pre-regular basis as we submit to them charges, our UBs. We submit to them, Medicare pays those UBs, and then they accumulate them. And there's a worksheet called the PSNR, Provider Statistic and Reimbursement Report, that we can download off the CMS website that allows us to look at, during the year, all of the charges that have been submitted to Medicare. In this case, outpatient charges are here in column 5. For the radiology department, if we take the charges that we submitted to Medicare, and we multiply it by that ratio of cost to charges, the 0.38, we come up with what Medicare costs are. In this case, it's $510,000. That is what we will get paid for the radiology department by Medicare for this whatever fiscal year that this is looking at. If we add them all up, in this hospital's case, the total charges submitted to Medicare are almost $5 million. And the reimbursement, the Medicare costs, are $3.2 million. So Worksheet D Part 5, this is the calculation then of how we come up with Medicare costs for outpatient services. Now for inpatient services, remember I said that there was a 2-part calculation? In the 2-part calculation, one is a worksheet very similar to this for the ancillaries, and then there's a second calculation that is we're trying to figure out the cost per day for nursing services. And that's what we're going to look at right here. This worksheet D-1 is this calculation of the nursing costs. So we calculate the nursing costs per day, we multiply it by the Medicare days, and you come up with payment for routine or nursing. And then the ancillary is the same exact calculation we just did for outpatient, but it's just for inpatient ancillary charges. I don't want to get too caught up in this worksheet because this one we can get bogged down. But let's just, if we turn to our handout and we look at page 23, 24, and 25, you can see ultimately what we're doing is we're loading in. If you have, and let me just flip here. Halfway down the page is this $3.6 million. Now let me grab my little arrow guy. The $3.6 million. That's that same $3.6 million that we calculated on that worksheet B, where we started with our direct costs of nursing. We allocated all of those overhead costs, and we came up with $3.6 million. Essentially, if you take that $3.6 million, you carve out some swing bed services, and you divide by the patient days, you come up with a cost per day in this case, and on your handout, this would be page 24. You come up with a cost per day for this hospital of $801. if you multiply that $801 times the Medicare acute days, remember going all the way back to the statistics page, it was like 2,097. You multiply $801 times the 2,097, you come up with the Medicare nursing costs of nearly $1.7 million. To that, you add the ancillaries, and I'll show you the ancillaries on the next page of this handout, on page 39 of this presentation. If you add the routine to the ancillary, you come up with the inpatient costs. And in this case, this is the worksheet I was just talking about. This is your worksheet, another one of your worksheet Ds. This is inpatient. We pick up the ratio cost of charges that we calculated back on the C schedules, multiply them by your Medicare inpatient ancillary charges, and you come up with your Medicare inpatient ancillary costs, the $1.6 million. I'm going to go backwards now, so I'm going to take that $1.6 million. I'm going to go back, add it to drop it in here. We add the the nursing piece, the ancillary piece, you come up with your costs. For this critical access hospital, we just calculated the Medicare costs on an inpatient, outpatient basis. There's a swing bed calculation, but it's very similar to the inpatient. The last schedules, and then we're going to wrap this section up here with the cost report. On the cost report is your settlement schedules. Essentially, your settlement schedules, they take with what your costs are. They increase your cost by 101%, come back off your co-insurance and deductibles. Then they'll compare to what they paid you during the year, and there's a settlement, either a positive or negative settlement. Worksheet E, Part B, this is for outpatient. This is your outpatient calculation, and that's in your handouts, page 28. Worksheet E2 is your swing bed, and that's on page 31 of your handout. And worksheet E-3, this is your inpatient hospitals. This is your acute, and that's on page 32. So if you want to flip to your handout, so this is your outpatient. Here's your costs, and the costs were your costs, and this is multiplied by 101%. You back off your co-insurances and deductibles. Medicare is going to essentially pay you $2.4 million. We generally like to see, for many of you, in addition for bad debt, this hospital did not have any bad debt. I would have hammered them on that. There was a payout during the year of $2.7 million. Medicare only owed $2.4. This hospital owed back $331,000. Now, here's a real test for, I don't want to have an answer from the CEOs or CFOs, because this is, but tell me, well, let me start off by saying the way Medicare calculates how much they're paying you during the year is they calculate last year, they take last year's cost report, and they came up with a weighted average ratio for all the Medicare charges they come up with a ratio of Medicare charges or cost to charges. And in this hospital's case, let's say it was 60% or 65%. So all this year, every time you submit a Medicare outpatient charge, Medicare is going to pay you 65% of the charge. When we got down to the end of the year with this critical access hospital, there was a $331,000 payback. This hospital owes Medicare back $331,000. What would be a reason for this hospital owing back Medicare $331,000? And I'll give you a hint. This ties in last Friday's presentation with this Friday's presentation. I see somebody in Washington. Doug, I hope that wasn't you that answered. I hope that was one of your clinical folks. It was. All right, we've got a winner. The answer that one of Doug's clinical folks, and I do trust him, so I know that this is the case, was the increased volume. And if you think about what happened, let's say this critical access hospital had $3 million in Medicare charges last year, and the average ratio of cost to charge was 65%. This year, the volume actually increased. We had maybe a 20% increase in outpatient volume. What happens when our volume goes up to our cost structure? Is our ratio of cost to charges going to stay the same? Is it going to go up or is it going to go down?
Down.
It's going to go down, right, because essentially, going back to last Friday's presentation, we've been able to dilute our fixed costs. So as we increase our patient volume, our cost per unit of service goes down. So at the end of the year, instead of getting, when we actually do the cost report, we may find that instead of getting a 65% ratio of cost to charge for Medicare, we may be down to 55%. But ultimately, Medicare is going to pay us our costs. Another reason why this might have happened is this hospital may have said, you know what, our charges are really low at the beginning of the year, so we're just going to jack up our charges by 15%. If you just bump up your charges, volume stays constant and expenses stay constant, for Medicare, essentially, you're just going to owe all of that money back that Medicare paid you over and above what your costs were. So it's a really important thing to understand that within critical access hospitals, ultimately, you know, back to our discussion last Friday and a little bit earlier today, was that you're only going to get costs from Medicare. And the slope of that line is fairly stable or shallow. The E2 is the same thing. This is just for inpatient, this is your swing bed calculation. And what we're doing here is here's your routine piece. So this is your days. This is at $801 a day times your Medicare swing bed days. I think it was 612. You add to that your ancillaries. You add these two together, multiply by 101%, and it's right here. You compare to what Medicare paid us during the year. It looks like here they paid us too much as well. Another case where our volume may have gone up. The last is your inpatient E3. Again, here's what our costs were. We calculated what our costs were on that worksheet D-1. Back office and coinsurance and deductibles compared to what Medicare paid, and we were spot on this one. So anyway, this is the cost report, and I want to finish this section by saying, first of all, for the PPS hospitals that listened in and actually were able to stay in tune and awake through this, I think the information as department managers that you get from understanding, one, how your costs are being calculated, first your direct costs, and then break that direct cost into, think about it in terms of the fixed and variable piece of your directs. And then all of the costs that get allocated through overhead allocations, and essentially all of those are fixed. It really helps you think about the cost dynamics within your department. But then when you look at it and compare to your charges within your department, and really try to understand, if you are one department and you sit down and look at your cost report, and your charges are actually lower than your costs, what does that mean? Do you want to go in there and look and see what's going on there? Is there an opportunity to cut expenses or grow volume, or somehow, is there an issue around charge capture that you got to work on? But in the spirit of connecting business and clinical processes within small rural hospitals, I think having this understanding about how your costs are calculated is phenomenal as a department manager, and I encourage you to look at this. I gave a talk several years ago, and a director of ambulance called from, I'll just say from Arkansas, and he had heard some of the presentation, and he said, gosh, what they're telling me about my department just doesn't seem to make sense, and based on what you were saying. And we talked through the whole issue, and we ended up finding out that he was right on. His understanding was very more real than what his administration's understanding was, and a very interesting phenomenon. So I'd like to leave you before this weekend starts with just the fact that the cost report has incredible information in there. For critical access hospitals, not only is this great information, but it's how you get paid for a lot of what you do. So any final questions? It's almost the weekend here in Maine. Any thoughts, questions regarding the cost report? All right. Let me ask this. Is anybody awake? Doug Tanner is still awake. Bethany has written in that she's still sitting in her chair, which is a good thing. She's still alive and in her chair. Then I leave you this as a teaser for next week. Next week, what we're going to, excuse me, I guess we're going to take Thanksgiving. We're not going to be getting together the Friday after Thanksgiving. The next piece is we're going to really start to understand how to look at financial statements, both overall, your balance sheet, income statement of your overall organization, then start looking at drilling that down further and looking at the statements that you receive as department managers. And if you're not receiving them, I'm going to encourage every single one of you that's not receiving a monthly department to actual report to go demand one. Sorry, guys. But really start to say, I want to be accountable for my department, and how are we going to do that? And then the next session, we're going to look at how do we use the tools, the cost report, the information from the departmental action reports to evaluate some of our own departmental performance. So, hey, look, I appreciate all you listening in today. Have a great weekend. Have a great Thanksgiving, and we look forward to catching up with you after the holiday, excuse me. Take care. Have a great one. Bye.
Thanks, Eric. Okay, thank you everybody for participating. And Eric does have the 2